Introduction and Assalamu alaikum. I'm Fahad Aziz Rana and I'm a consultant gastroenterologist. I worked in the UK for about 12 years working in 2 transplant units. Both of them were, one of them was actually focused on fatty liver a lot. Most of you may have already known that the nomenclature was changed about 18 months ago, and now we are following the new nomenclature for fatty liver disease. We'll just go through it. It's not a very long presentation, so bear with me. I'll try to keep you awake while we go through them. What's fatty liver? We all know. Accumulation of fat, triglycerides on the surface of the liver. Of course. Thank you. So this is a healthy-looking liver, and then there is accumulation of fat on the liver. The first step is fat accumulation. The next step is inflammation. And the next step is fibrosis, scarring, cirrhosis. We'll go through them step by step. So this is the new nomenclature. I've tried to simplify it by making bullet points. If you find it confusing, there is another slide which sums it up. That's the next slide. So we'll go through the nomenclature and the wording of the nomenclature. So previously NAFLD, is there a cursor on this? Cursor has me. Cursor, iske upar cursor hai? Yeah, thank you. Previously in NAFLD, जो आपने सबने सुना होगा, very common word still used everywhere, is now called MAFLD. Metabolic associated fatty liver disease, metabolic associated steatotic liver disease. Sorry, it's a typing error from my side. Steatotic liver disease, MAFLD. Previously, it was non-alcoholic fatty liver disease. So NAFLD has now become MAFLD. And this is presence of fat on the liver without inflammation. Now, why did I use the word without inflammation? Steatosis is simply the accumulation of fat on the cells, on the hepatocytes, on the liver surface, under the capsule. Once they start causing inflammation, that's when it becomes steatohepatitis. And that's a different, we'll call it with a different name, which is the next one. And that's called MASH. Metabolic associated steatohepatitis. So steatosis and then steatohepatitis. What would you expect to be different in steatohepatitis than in steatosis? Would anyone like to guess? Any takers? Sorry? We'll just expect to see deranged LFTs, because mostly fatty liver is found incidentally. I mean, if I see 10 patients in a day, I would probably have 4 or 5 of them who have fatty liver. But one will have abnormal LFTs, 4 of them will have normal LFTs. So therefore, there needs to be a distinction between fatty liver without inflammation and fatty liver with inflammation. That's why MASL and MASH are 2 separate names. According to the classification. Alcoholic fatty liver disease, the process of fat accumulation is exactly the same as in someone who is a non-alcoholic person with fatty liver. The same process. Therefore, the name hasn't really changed. It's still alcoholic fatty liver disease. So ALD or ALD. And then we have metabolic and alcohol-associated fatty liver disease. So these are the patients who drink alcohol as well as have metabolic syndrome. These patients are now classed as MetALD. This was previously known as dual etiology fatty liver disease in the UK transplant units, DAFLD, but now it's called MetALD. The next one is fibrosis and cirrhosis. Any confusion so far? I know it's a lot to take in, lots of new names. Are there any questions, any confusions, or shall I move on? Okay, we'll move on. So this I hopefully will make it a bit easier for you to remember. So NAFLD is now MAFLD. Non-alcoholic fatty liver disease is now metabolic associated steatotic liver disease. And I think it's important that as clinicians, regardless of what specialty we belong to, we take up this new nomenclature just to be in tune with the rest of the world. NASH, previously NASH, is now called MASH. It's an easy one to remember, I hope. So previous one was non-alcoholic steatohepatitis. The new one is metabolic associated steatohepatitis. ALD is still ALD, nothing has changed. DAFLD, as I mentioned, in the liver transplant units in UK, this was dual etiology. So patients who had metabolic syndrome and drank alcohol heavily would come in for a liver transplant. We would label them as DAFLD. We had to give them a label so they could be indexed and they could be given an ICD code, and therefore we could proceed. So DAFLD was used in the UK. But they have been relabeled as MET-ALD. So they have metabolic syndrome and they have alcoholic liver disease. And I think MET-ALD is actually much easier to remember. The next two, there are some specific causes which cause fatty liver disease: medication, pregnancy, etc., as we all know, and then cryptogenic fatty liver disease. I hope that's clear and there are no queries so far. Moving on. Now, the cardiometabolic risk factors. So whenever we say metabolic associated, we need at least one of these risk factors to be there for it to qualify as a metabolic associated liver disease or steatotic liver disease. So number one is obviously high BMI, and in this scenario, it's more than 27. Pre-diabetes or established diabetes, hypertension, high triglycerides, and low plasma HDL levels. So if any of these 5 risk factors are present, that patient will fall into the category of metabolic associated steatotic liver disease, or MAFLD, which may even become MASH at some point in the future. This was a worldwide study by Wong et al. In September 23. It showed that 1/3, so in this room, if we have 100 people, about 33, 34 of them have fatty liver disease. With or without inflammation, obviously we don't know, but most likely without inflammation. And 5% of them progressed to cirrhosis as per this study, but there are different studies which have shown the number can be as high as 15%, and it can be as low as 3% in other countries. The incidence, unfortunately, continues to rise, and I have a world map actually on one of my slides which shows the distribution of fatty liver disease. I'll show that to you in a moment. So just remember these 3 people, and one of them has got fatty liver disease. Any etiology, but that's a big number in given in a population of, let's say, Pakistan. Out of 25 crore people, that's about 8.2, 8.3 crore people have fatty liver disease. That's a huge number to tackle. And 5% of them will actually develop cirrhosis. That's another problem we have to face in the upcoming years. This map is from the European Society of Journal of Hepatology. And the darker the area is, the higher the incidence of fatty liver. Unfortunately, the data from Pakistan wasn't very robust, as you can imagine. We would have probably given them data from Lahore, Karachi, Islamabad, Peshawar at best, perhaps from Quetta, but not from inner Punjab or inner Sindh. And you know, I think there would be pockets which were missed because the number of patients I see in clinic with fatty liver, this doesn't even come close to it. But so my calculation would be that we are sitting at least at the 40 to 50% mark in terms of fatty liver disease incidence-wise. So 40 to 50% people in Pakistan suffer with fatty liver disease. It's the same as diabetes mellitus, 40 to 50% people. Excuse me. So causes of fatty liver. There are some obvious ones, but then there are some not so obvious ones. For example, a patient with a normal BMI came to my clinic with fatty liver. I did a FibroScan on him, which was slightly abnormal. He didn't have fibrosis. Tall young gentleman from the army, and he kept asking me, why do I have fatty liver? Triglycerides were normal, HbA1c was normal, and turns out I sent him to the endocrinology team, and turns out he had insulin resistance. They ran some tests which are beyond me, but he had insulin resistance, but he was not obese. So these are very rare cases, but mostly you'll see obesity, diabetes, high cholesterol and triglycerides, excessive alcohol consumption, genetic predisposition, certain medications, and viral infections. They can leave a trace of fat behind, which is part of the healing process. Normally, it's reversible. Mostly, it's reversible, actually. So this is the list of causes of fatty liver. It's not absolutely comprehensive, but it covers the major reasons of why someone may have fat on the liver. Happy for me to move on? Symptoms. So mostly, as you may have seen, there are no symptoms. They come to clinic, they have other problems, perhaps gallstones, bloating, APD, and then we just get an ultrasound scan done, and incidentally we find fatty liver. Some of them may have abnormal LFTs, some of them will have normal LFTs. The ones with abnormal LFTs, they are the ones we need to keep an eye on because they already have steatohepatitis. So they're not steatosis anymore. Steatosis is when there is fat sitting on the surface of the liver and it's not doing any damage so far. And that's reversible, completely reversible. Steatohepatitis, to some extent, as long as there is F0 fibrosis, F0 fibrosis on the FibroScan, is also reversible. And this is where we need to ask them to come to regular follow-up, give them the guidelines. What I've done in my clinic is I've actually printed out a sticker from the European guidelines and the British guidelines, and I stick it on my folder and give it to the patient. Mention their weights, BMIs every time they come to my clinic, and LFTs in front of them. And I show them the betterment or the improvement in the LFTs and the FibroScan improvements as well. So that's an objective A star for the patient that, yes, I've made some good strides and moving forwards. Other symptoms, fatigue, weakness, abdominal pain, jaundice in advanced cases, as I mentioned, when it's decompensated. And that's it, really. So how do we diagnose this? It's mostly with blood tests. LFTs are deranged, fasting lipid profile, HbA1c. We'll do the weight, obviously. We'll do the BMI, and then the imaging, as I mentioned. FibroScan, and in selected cases, like the ones with normal BMI and a fatty liver, we'll do a liver biopsy. Or someone who's got or had a viral infection and has got deranged LFTs which fit the pattern of fatty liver disease, i.e. AST over ALT ratio of less than 1, we'll then go and biopsy them. But we don't normally have to biopsy these patients. It's only in very, very, very selected cases. So role of LFTs. This is something we encounter every day. So someone's got normal LFTs and they have fatty liver on the ultrasound scan. These are the people who have one of the risk factors we mentioned earlier, and they have steatosis. So we just tell them, listen, your early stage fatty liver, you can reverse this, you need to do X, Y, and Z, and inshallah you'll be out of it. So we have to give them reassurance. We shouldn't abandon them, And most of these patients actually do come back to my clinic in 6 months, especially younger males and females, both alike, to say that actually I've done it. I've lost 10% of my body weight and I'm back to normal. LFTs are normal. Ultrasound scan actually shows there's no more fat on the liver. So it's actually a big achievement for the patients as well as for clinicians who guide them through the process. Fatty liver with inflammation will see abnormal LFTs. ALT and AST are both raised, and this is known as steatohepatitis. Now, once again, depending on the fibrosis score, this is also reversible. So we shouldn't say that this is something we need to give up on and move on. We should encourage them to lose weight and follow the guidelines, and inshallah we'll see improvements in these patients as well. And just a little sort of reminder that AST over ALT ratio typically less than 1, i.e. ALT is higher than AST, indicative of fatty liver. I'm sure everybody knew this. Progression, normal looking liver, first stage steatosis, non-alcoholic steatotic liver. These patients have normal LFTs, so 25 to 30% of the normal population. NASH or MASH, new terminology, steatosis with inflammation and deranged LFTs, about 30% of the population. And then we have cirrhosis, as we said, 5 to 15% in published literature, and then HCC. So up till here, things are fairly, depending on the fibrosis score, are fairly reversible, but after this, unfortunately, there is no reversibility. And once this happens, patients may need a transplant. Management, lifestyle modifications are the most important management. Patients ask for magical drugs. There are no magical drugs out there. There are no magical potions out there. We meet with our endocrinology friends, and there is some promising data from GLP-1 antagonists, and hopefully they will be in the picture in the next few months or perhaps years. It takes a while for the liver society to accept what the endocrinology society says and vice versa. But I think it is something that will be considered in future for fatty liver disease patients as well, which will be a good thing because it covers all the metabolic risk factors and as well as get the patient rid of a bad liver. So yes, why not? But for now, balanced liver-friendly diet, rich in fruits, vegetables, and whole grains, exercise, and the most important thing here is 10% weight loss. If the patient has a high BMI, we'll ask them to lose 10% of body weight. If the patient has normal BMI, studies have shown that if they lose 5% body weight, the LFT is reversed and go back to normal. So weight loss is still important in both categories. And then we have to manage their dyslipidemia and hyperglycemia, and alcohol cessation for people who drink alcohol. There is no medication for fatty liver disease, regardless of what anyone out there tells you. There is no licensed drug to reverse fatty liver disease. Absolutely not. So please do not be reliant on those medications to reverse fatty liver. It's not going to happen in 100 years. Prevention, adopting a healthy lifestyle, public health initiatives, which are actually being taken. We had our Fatty Liver Disease Day in Umar Hospital, both branches and some other private hospitals joined in. And we just checked their HbA1c, BMI, and made a list of patients I did free fiber scans on. So something that we need to work on as a family of doctors to guide the public through this problem, which is getting worse, unfortunately. So in summary, fatty liver is a very common condition. As a conservative number, 1 in 3 people suffer with it, but according to the other papers that I've seen published, I think it's it's about 4 in 10, so 40% people. Early detection and lifestyle changes can change, not, I won't say can, they actually do change outcome. Aim is to reverse fat deposition on the liver, reducing the inflammation and reducing the progression to cirrhosis. And please seek early medical advice if fatty liver is diagnosed, even if it's with normal LFTs and it's just a fatty liver on the ultrasound scan. And with that, I thank you for your time and your patience.